if you look at what is happening in many states, the fact that some states have been performing much better, their capacities are much, much better, other states haven't. And once you have the system, you are getting untied funds. Will those states much in need of ramping up not just public investment in health, but a better delivery system, better human capacity? Will they be in a position to do so or not? And while India has to definitely step up its public investment in health in a very big way, we are the laggard among a group of cohorts that we are around same per capita income. We are tremendously laggard in that. How does India go about doing this? Another issue, political economy is equally important. So glad that we have a very eminent panel who will be speaking, discussing. The Health Secretary is not able to make it, Mr. Harsha, but we have a very eminent panel of the head of our National Commission for Women, Lalitha, Kumaramangalam. We have Dr. Anand, Secretary, Minister of Statistics and Program Implementation. We have Dr. Poonam Khetrapal, Director WHO, and we have Dr. Shamika Reddy, the President of the Public Health Foundation of India. I am not prioritizing them, this is in the order given on the sheet. So this is not in terms of hierarchy, this is not in terms of order of precedence. Before I invite Shamika to come and make her presentation, I would just like to invite you people to become involved in our institution, the Nehru Memorial Museum and Library. If you look at our programs that we've been doing, 2 days ago we co-hosted along with the millet people the launch of the National Millet Network. And if you again linked with health in so many big ways. Mr. Devegoda made Ravi Mudde of Mandya famous all over the country. If you go to Mandya today, they're eating rice, not Ravi Mudde. The Rava dosa in Mysore is more an exotic dish than a standard dish. The fact that we have all these issues that we felt that Hinduism should be involved with. We are doing a book reading with Shashi Tharoor next Tuesday, I think. We are doing it with Janaki Devi and the Japanese University, a workshop on cookbooks of India across the region. The reason I'm mentioning all this is that we have something for everybody, because the whole idea is to enable the creation of a platform where people from different disciplines can meet and interact with each other. So if I'm in the health sector, for me, India's crisis is only in the health sector. If I'm in the education sector, I'm horrified that more than 50% of children in class 5 cannot read class 1, say, in the library books. If I'm in the field of environment, well, the list is too long to decide. All of them are right, but to get a larger picture, an interdisciplinary platform is always good. We don't hope to become something like the NITI or whatever, but this bring a platform where all of you can come, join, talk, listen to each other. Please sign up on a mailing list. Come when you feel like coming. As I said, we have so many different things on offer for all of you that I'm sure that you will find this place interesting. And you will enrich us by your participation. With this, I welcome you, all of you once again. It's so good to see so many people in this hall on the subject of health and morbidity, which, as I said, I think is a very, very important thing. So thank you very much for coming here. Dr. Shamika, Ravi, over to you.
So, good afternoon, and thank you, Shakti ji, for not just the venue, but also being such a gracious host and supporting facilitating this gathering. But let me also start by saying we are so heartened by the fact that so many of you could take the time out to come and have a dialogue on healthcare. It's an area, I think, which needs serious rejuvenation as far as public policy concerns in India is concerned. Now, the scheme of things will be that I will quickly present the evidence because, the event today is titled Health and Morbidity in India, Evidence and Policy Implications. So we'll start with the evidence, and then we will call the panelists to have a discussion on the policy implications from their varied perspectives. So let me start out by giving you a sense of an overview of where this research originated and what is the basic sense of it. But before I do that, there are many in the audience who have been part of this study. In fact, my co-author, Rahul is here, who is at the Niti Aayog now. There is Dr. Archana Singh from AIMS, who was very critical in helping us understand the alien data. Dr. Mudit Kapoor from ISI, who has helped us a lot with the statistical analysis. So it's good to have a gathering of friends who sort of know the zeal with which we're coming into at this topic. So as an overview, let me start by saying that the 10 years that we studied from 2004 to 14 were very instrumental in terms of moving the policy needle as far as healthcare sector was concerned. And the big flagship programs that the government during those 10 years started off with. One was, of course, the NRHM, which later morphed into the NHM. And as you know, as you're well aware, the NRHM had an overwhelming focus on maternal and child health. But along with that, we also had a serious push towards spreading the outreach of publicly financed health insurance schemes in India. So we've had, starting with the Rajiv Arogyashri in Andhra Pradesh, we've had the RSBY in 2008, which has now got outreach throughout the country. Many states also have their own customized, health insurance programs. And in fact, we have some other research papers that look at implications of only, some of those specific programs. But this is more of a general equilibrium study, and I'll tell you why. But first, these were the big policy initiatives taken in the 10 years that we look at. Now, why these 10 years? As data scientists, as economists, we are always bound by the availability of data. And this is where Dr. TCA, who's here, who will take all the tough questions on the data, because we use his data. We use the National Sample Survey Organization's 2 rounds. We use the 60th round of 2004, and we use the 71st round, which is 2014. Now, why these 2 rounds are special is because they actually have details on health spending. And they also have certain measurements on ailments. So what you have is a household survey data across 10 years with certain details on health spending and morbidity, certain kinds of ailments. So this gives us an exciting opportunity to actually compare where the country has gone from the viewpoint of households. Now, I will also point out to you where are the discrepancies in the data. Because we know that from the institutional point of view, if you ask, then we know that 25% of India has some kind of health insurance. But if you look at the households and you talk to the households, that data is much lower. Okay, that number is far lower. So again, even though gaps that you see in the system are quite interesting, and they become policy relevant issues in themselves. But specifically what we focus on are the health-seeking behavior. How has that changed in 10 years? And by that I mean, how much is OPD, how much is IPD? Are households more likely to get hospitalized for similar ailments? What is happening as a result of specific policy initiatives like the Janani Suraksha Yojana, which was a flagship program under the National Rural Health Mission. And the Janani Suraksha Yojana becomes interesting in why we sort of look at this, not just because it is a huge policy initiative on behalf of the government, but also, the way it was implemented gives us the statistical, advantage of actually comparing. We are able to say something causally. We are actually able to tell you that it's because of this scheme that certain things happened, that hospitalization changed in a certain way, that the use of public hospitals started, expanding in certain ways. So we look at the changes in health-seeking behavior with specific focus on the Janani Suraksha Yojana and the publicly financed health insurance schemes. Then we move towards the change in the burden of healthcare, which we are going to measure as something standard in the literature, which is the out-of-pocket health expenditures of households. We look at what is happening to catastrophic expenditure. Catastrophic, for those of you who are not from the health research, is, if your healthcare expenditure is more than a certain threshold of your total expenditure, it's considered catastrophic. And the usual benchmarks are 10%, 25%, and 40%. So these are really different benchmarks for looking at how much of a health shock did you face in terms of expenditure. So we look at that. And then we also look at impoverishment caused by health shock. So if households are now falling below the poverty line simply because they've had a health shock or they've had series of health shocks, then we say that this is the kind of impoverishment that has happened over these 10 years due to healthcare. And we are able to tell you what is happening on that front. Then we look at health financing, again because NSS does have detail on how did you finance the healthcare expenditures. So we tell you whether it is from borrowing, savings, it's from, it's through insurance. So we look at different aspects of financing of healthcare expenditures in India and how this has changed in the 10 years from 2004 to 14. And finally, which really becomes the segue into the next round of study at Brookings India in healthcare, is the interstate variations. What the NSS gives you at a national level, you are able to actually also come up with representative statistics at the state level. So you know that within the country, and of course now with the fiscal devolution and after the 14th Finance Commission, more and more health policies will originate at the state level. Which is possibly a good thing, and the reason is because you have such variations in terms of just the existing healthcare and the kind of morbidities that different states are faced with, that you need localized policy interventions. That in the paper, and you will see the report by the end of the program, that section is relatively small, but that's where our next line of study is. Okay. So let's start out by looking at what has happened to Indian households broadly over these 10 years. Well, India has become more urban. It has many more toilets. There are far more literate people. Now, in terms of the latrines or the toilets, remember this is 2014. So this is before the Swachh Bharat Abhiyan started under the current government. Now, if these are households that are telling you that more latrines are available, that they have actually built many more, these are self-selected group of households that have actually gone and built their toilets. So there is something, the difference or the discrepancy that we face today in terms of availability of latrines and the usage of toilets, that problem is really not there in this data because these are toilets that were not created under a large scheme, but this is just more households building toilets because of sanitation, obvious reasons. Many more households have health insurance, so these are the broad statistics, broad changes. And as you can realize, that all of these really affect household health. And we are going to be controlling and analyzing our results, having, disaggregates across these set of points. So in terms of, this is what I just told you in terms of, those 6 bullet points, is that life has changed for an average Indian in these 10 years in very serious ways. But if I were to now put specific statistics broadly in terms of healthcare, then we see that, in terms of just reporting, 7% more Indians are likely to report that they are sick. And for income levels and levels of poverty that India is grappling with, these are, it's good when reporting of health goes up. It just tells you that people are seeking more healthcare, they're more aware about morbidities. So it's not really, it shouldn't be read as it's increase in morbidities, it's more like a reporting or a usage issue. In the urban areas, you see that this has increased by 18%. So urban Indians in those 10 years, 18% are more likely to report that they are sick. And amongst these, the biggest increase, if you look at gender, then 14% more women are likely to report that they are sick. If you look at just what kind of healthcare they are seeking, the increase in OPD is 9%, which is not that much if you compare it with the fact that IPD, or inpatient department, which means hospitalization, has had a massive increase. We see that in these 10 years, there has been a 42% increase in IPD cases. Now looking at private and public care, we are seeing that 75% of OPD is exclusively private healthcare, okay, which is a very big number. But what is heartening in some sense is the fact that this has actually fallen. This has fallen by 7% in this 10 years. This dependence on, exclusive dependence on private care. But even as of 2014, more than half the IPD is basically through private hospitals. Okay. But there are serious gender implications of what the NSS is throwing at us. And the reason is, this is basically to show you that in these 10 years, if you just look at households who are reporting whether they are hospitalized, you see the biggest increase that you see is of rural females. So rural females are almost 75% more likely amongst the, to report that they've had some form of hospitalization. But if you look at public care, that the fraction that is actually going to public hospitals, IPD, then you see that rural females are showing a big increase in use of public hospitals. But men, whether they are in rural or urban areas, are less likely to use government hospitals. So it's more women, and I want to motivate now this from the point of view of the NRHM and the big push in the Janani Suraksha Yojana that we have. So a lot of this is now alluding to the movement we've had of more and more women moving towards hospitals for childbirth. That's the direction towards which I'm trying to take you. Now, what about childbirth versus other forms of ailment? If you look at IPD or hospitalization, then what you see is that, for all other ailments, the increase is much more in the private hospitals. Except if you look at childbirth, any form of childbirth, then the increase is seriously high in the public care. So people seem to be wanting more private care in terms of hospitalization, except for childbirth. For childbirth, we are seeing that use of public hospitals has increased significantly in the 10 years that we study. Now, if you look at JSY specifically, right now I have been showing you some of the statistics to broadly tell you that it's childbirth, it's rural women. But now, what if I look at JSY specifically? And let me tell you, statistically, these are difficult. This causal relationship is very difficult to make. But the nature of the data is such, and the way the JSY was implemented, it was not a one-shot implementation. It happened in a very staggered fashion. So we are able to use, statistically what we call difference in difference, and certain econometric methods to actually show you a causal link where we see that Janani Suraksha Yojana has led to more public hospitalization overall. It has increased institutional delivery in India by 15%, and it has reduced delivery at home by a commensurate amount. So if the focus of our policy was to have more and more childbirth in institutions, because remember, maternal mortality and infant mortality were the two goals that India had signed on to as far as the Millennium Development Goals is concerned. And this is where Dr. Kechapal will educate us more on where the global standards and what should be the policy movements within India to align ourselves with some of these global policy are concerned. So we see that commensurate with what the objective was, we seem to have succeeded. India does have many more childbirths in hospital than we did before, and with an equal decline in deliveries at home. Now, what about the out-of-pocket burden for households? If you look at overall health burden, meaning total expenditure from the private pockets as well as the government, then we see that in these 10 years, out-of-pocket burden has fallen marginally. Okay, from 70 it has fallen to 67. But if you look at what is the fraction of OPD in the total out-of-pocket, remember OPD is always a very large. In fact, 3/4 of your total out-of-pocket is mostly just outpatient consultations with doctors. It's not hospitalization. This we see that in the 10 years, this has actually fallen by 11%. So overall burden of healthcare to households is now moving, which used to be significant, towards more IPD. So India is moving towards greater incidence of hospitalization overall. Now, if we look at now what is the difference in the IPD versus OPD, okay, as far as the health burden, expenditure burden is concerned, then you see that there's a 13% increase in the real out-of-pocket expense for OPD, but there is a 66% increase in the real IPD expense per household. So these are at the household level. Now obviously there are many more incidents, so you have many more OPDs, you have many more IPDs, but I will also show you data on what is happening to expenditure per case. So it is not just that people are going for many more hospitalizations or doctor consultation, but per visit, the costs are increasing, okay, and hospitalization costs are increasing much more. If you just look at the data and try to compare this, the variations across urban and rural, then you see that there are, very serious disparities. The annual real out-of-pocket increased 24% per person in rural areas, okay, in 10 years. And this is real, but it seems reasonable. but it increased 50% in the urban areas. So you're seeing that now per household, urban households are spending much more. The growth in their expenses, health expenses, has increased much more than rural India. And the increase in the out-of-pocket in rural areas is concentrated. Now, what is interesting is not just the averages of rural versus urban. What you also want to understand is for each of these, what is the distribution? Because in each population you have quintiles. You have very poor, and then you have the relatively affluent. And what we see is that, you see this, and I'm sorry this is small, but the whole idea behind this is, the green block there is telling you in the rural population, the increase in out-of-pocket is essentially limited to the extremely, poor households. It's the first quintile, the bottom quintile. So it's the poorest that are experiencing the largest increase in out-of-pocket health burden in rural India. But if you look at urban India, then you see that increase is actually across the quintile groups. So in rural areas, we see that not only is the average increasing in terms of health burden, but overall distribution, it's like people across different income groups. In this case, it's not income because in NSS, we usually look at quintiles by the consumption. Consumption is far better measured. And you see that across the different quintile groups, people's out-of-pocket burden is increasing. Now the expenditure per case, because we know that not only are people spending more, but per case, per visit, the expenses are more. And what we see here is, we were startled, my team, because what we see is in the 10 years, there has not been a real increase in OPD expense per case. So if you just deflate it by the price, then you see that per unit, the OPD has not increased, but the rural-urban gap that you have, that has just been widening for the OPD. Okay? Urban areas are paying more. In the IPD, and again, this is the smallest font you will see today. In the IPD, this is actually, the story is a little more, disconcerting. Is the average expenditure for IPD has increased significantly overall, as you can see, in terms of 1,500 more. And this is real increase, 1,500 more increase compared to, overall. But this overall increase in the IPD per case is largely driven by the increase in the urban IPD. You see that in rural areas, the increase in their cost per IPD has not been that much, as you see in urban areas. In urban areas, we are seeing that households in these 10 years are now spending around 2,650 rupees more per hospitalization case than they were earlier. So this is actually a significant increase. And this includes doctors' fees, medicines, diagnostics, and so on. And if you disaggregate the data, then you see that urban Indians are having to now spend per visit much more on each of these disabilities. So the hospitalization burden on urban India is increasing disproportionately more than the average expense of healthcare in the country. What about impoverishment? Now the way you calculate is that you look at the below poverty line, what is the fraction of the population that is poor? And if you account for now the health expenses, now you see what is the fraction now, having accounted for that. And we see that that difference is actually the same. So in the 10 years, incidence of impoverishment caused due to health has remained at 7%. So even in 2004, you had 7% of Indians getting impoverished because of healthcare. That has remained the same despite all our policy initiatives. Impoverishment due to healthcare has remained 7% even in 2014. Now in terms of financing, and this is where the data issues come up. That if you look at the data, that is 2004 and 14, then we see that 1% of India had any kind of health insurance in 2004. And 2014, this has risen to over 15%. But if you look at the World Bank data, which has been put together by talking to institutions and government, which means more from the supply of insurance, so from the institutions, you see that 25% of Indians are supposed to be covered. Now this is a big gap. Okay? And we need to understand what is this gap. Is it that people do not know that they are insured? So while the institutions might be insuring them, they are not aware that they are covered, and therefore respond like this in the household survey? Or is there something else happening that we should be concerned about? Moving on, beyond the aggregate, if you look at how are people financing their healthcare, then we see that, increasingly they are relying on their own health, own income and own savings. The reliance on borrowing has come down significantly. The sale of asset has come down significantly. And this is just telling you the country is getting, is less poor. You're just better off, so you spend more on healthcare. Now, in terms of insurance coverage, and this is very interesting because for us, in the last 10 years, expansion of health insurance has been one of the policy priorities. What we see is that if you just compare the overall insurance with the public insurance across the quintile groups, then the lessons are that private health insurance covers largely richer and urban households, and that is anecdotally, something we agree with. But what was surprising and heartening, quite encouraging, is that public health insurance is more evenly distributed across rural, urban, and across quintile. So this is actually, it's good. Now moving on, if we are to look at, there will be some amount of statistics thrown in, but the whole idea is we want to look at expansion of all this publicly financed health insurance scheme. Has it had impact on health burden as measured as the total out-of-pocket expenditure for a household, the catastrophic expenditure of a household at 10, 25 and 40%, and overall impoverishment? And it was puzzling, but we grappled with this data over a year, and the results are consistent. That we do not see a big significant improvement. In fact, we do not see any significant association between coverage of publicly financed health insurance schemes and health burden as measured by out-of-pocket, catastrophic, or impoverishment. Okay, now that could be a function of just the size. It's 15% we need. But NSS data is what it is, and even 15% is a large enough sample. So I don't think it's an issue with the data. We need to seriously look at the way some of these health insurance schemes are designed, what is covered, do people know, financial literacy that might perhaps have to go with it, but also moving beyond insurance to other forms of financial instruments that could potentially finance healthcare expenditures. But what about insurance and hospitalization? And this is the last slide that I'm going to show you. So even though public health insurance is not showing big, significant impacts as far as health burden for a household is concerned, what we do find is that it is significantly associated with more hospitalization. And your expenses are not increasing. What it is telling you is that public health insurance might not have lowered the expenditure burden of households, but it has definitely increased access to IPD care. So if you had some kind of morbidity or an ailment before, over these 10 years you're seeing more households access these forms of IPD care. So I will, in the interest of time, and because I'm really looking forward to the panel discussion, I will not get into the details of the state variations, but the report will be made available to you. I recommend all of you to give it a good look, and do come back to us if you have any comments or suggestions. At this point, I request Dr. Harsha Singh to please call the panel, and we can do the launch.
Thank you, Shamika, for the presentation. And thank you, Shakti, for being our partner in this initiative in today's program. And we hope to partner in many others as well. As Shamika was explaining the data, Shakti and I were trying to explain why the result was the way it was. And both of us agreed on the conclusions, but that doesn't mean that we were necessarily right. So it'll be very important for us to really get the right questions from you based on this presentation and discussion. As Joan Robinson said long back, very well-known professor of Cambridge University, that the important thing is to ask the right question. Anybody can answer that once it is there. So we hope to provide more answers, but to provide those answers, the approach which Shamika and Brookings India is taking is to actually look at data and look at data in a way that we have an orderly set of data, consistent to the extent possible, which makes sense. We see the differences in coverage, we see the differences in possibility of answering questions, and then try and seek policy initiatives or interventions which will address the primary concerns which arise from the data. And those are some of the things which the panel will be discussing today. So data for us is very important. We are also going to look at many other aspects of health in India, including the quality of district level hospitals. Where are the deficiencies, how to improve them. We are going to look at the use of digital for improving access to health. We are going to look at gender related health concerns, and hopefully we'll come out after a little bit of more effort and expertise which we are trying to gather together with working in the field, taking inspiration from the statistics which we have had the benefit of this study, to actually collect primary data as well as secondary data on health relating to women, and come out every 2 years maybe with a large report on that. We have many other such ideas, but as far as our policy implications are concerned, we look forward to the interaction with you, because in some sense you are our most important resource. So with these words, I now would like to invite the panel. May I request Srimati Lalitha Kumaramangalam, Dr. T.C. Anand, Dr. Poonam Khetrapal, welcome, ma'am. Dr. K. Srinath Reddy, Dr. Shamika Ravi, Shakti. So we have, as Shakti Sinha has informed us, we have a very eminent panel. C.K. Mishra couldn't come due to a sudden meeting which came up. So we have Srimati Lalitha Kumaramangalam, Chairperson, National Commission for Women, Dr. T.C. Anand, Secretary of the MOSPI, Government of India, Dr. Poonam Khetrapal, who's the Regional Director for the region's office on WHO, so not just India, but the Southeast Asian region also, and Dr. Shrikant Reddy, President of Public Health Foundation of India. We look forward to benefiting from them. I request, Shamika, would you like to take on, or Shakti, would you like to say a few words? Thank you.
We just request all of us on the panel to release the report.
Thank you, Harsha, and thank you, Shakti, and thank you, panelists. Thank you all for your time, and for actually, I know that each of you have been thinking specifically about certain aspects of the evidence which the data is throwing up, and what it means for India in terms of policy implications moving forward. So let me start out with you, Lalitha. We know that the last 10 years, at least the period that we have studied, 2004 to 14, there has been a serious emphasis on women's health. Unfortunately, most of that emphasis has been limited to maternal care. What are your views on this, and what are the specific policy recommendations that you would make in terms of where we should head from here?
I'd like to say one thing, that you're right, most of the nutrition that we talk about when it comes to women is around pregnancy. But there are a few facts that I'd like to bring to the attention of those in the audience. I'm sure many of you already know it, but let me reiterate them. One is that good health has to be lifelong. It can't be that you are only healthy during the period that you're pregnant, especially when it comes to women in the Indian context. You have to generally, and it's also a fact that the health of the child, unborn or even after the child is born, a lot of it depends on the mother's health. And these are general, generalities that are often not taken into context. Nutrition in India has become, it's become like a sort of game that's played. We have forgotten the lessons that we've learned in the past. Indians have depended a lot on local foodstuffs, and when now the nutrition programs that are run by the government of India often don't look at contextualizing. For example, let me say, when you talk about spinach as one's diet, every region in India has got its own type of spinach. Now, spinach is an English term. In down south, it's called kheera. In Bengal, it's called shag. In Delhi, it's called something else. And we have different types of this food. But we have forgotten to add, or perhaps we've forgotten the efficacy of our traditional foods, which have been a part of our lives for generations, and started to depend too much on processed foods, whether it's multivitamin pills we are popping, whether it's the lack of reliance on foods that may be rich in iron, etc., and various other nutrients, and started to go into, I don't know how to term it because I'm not a health professional, but started to look at additives as a solution for nutrition, whether it's during pregnancy, before or after. Also stop to look at the lifestyle approach that we need to take, both. Many of the diseases that women suffer from in India are due to a lack of health. When it comes to things like genital and reproductive health, it can cause cancers, it can cause a lot of other diseases which women don't traditionally even talk about. And what about anemia? Anemia is endemic in this country. Anemia is bad for everything. It can, obviously it does affect the child, the health of an unborn baby, but it's an endemic disease in India right from childhood. It's a fallacy that Indian women are only anemic after they have achieved menses, that is, after their first periods they start getting anemic. That may exacerbate the problem, but even in a state like Tamil Nadu, which is considered one of the healthier, better educated states, etc., the average anemia is about 42% or amongst girls from the age of, I'm told, 6 to about 35, 40. And there are many reasons for this, but the thing is that the solutions we look at, we have very box solutions. In India, when you say nutrition, in school, at school level, it's about giving, of course, the noon meal scheme is there, but the noon meal scheme itself has a big dichotomy between hot cooked home meals or between giving them the packaged additional macronutrients added to the food that is distributed to children at school level. And then there's the whole problem about distribution itself. I'm not going into those nitty-gritties, but the fact is that we do not have one approach that could be applicable across the country, adaptable to local foods and habits and cultures, etc. When it comes to women, there's also, of course, the mindset that we talk about when it comes to everything that has to do with women. Women eat last. They are not taught that health, that food and nutrition is part of health, not just survival. And this is a huge mindset that needs to be changed. From childhood, girls and women in our country, we eat last. which obviously means in poor households that you eat to get hardly anything, and added to it, a lack of nutrition. When it comes to health in general also, you will find that women's health is often the least addressed and more often than not the worst addressed. I don't know if we have statistics for things like insurance. The percentage of women who are insured versus the percentage of men who are insured across states, across caste, creed, etc. and age. Unfortunately, I don't think India has really data that is disaggregated data. Most of the data in this country is just general data. There is very little disaggregation. So we don't know the difference in data available between male and female genders. So that is something that I can't just comment on, but from what we have seen, across the board, health is not, I think, an indicator, it should be an indicator of development or empowerment or whatever words one wants to use. But in the case of women in India, it isn't. Health is not really considered, it's not very important. We talk about education, we talk about economic empowerment and all of that. But almost always, health and nutrition in India is only concerned, women are only supposed to be concerned with it when they are pregnant and about to have a baby.
Thank you, Lalitha. In fact, one comment that I have to the evidence that you asked in terms of insurance is that, we worked on a paper a few years back based on microfinance institutions. And as you know, most microfinance institutions in India cater towards women. Many of them experimented with selling health insurance along with the name. But what came out, very stark in the evidence, in the data, is that women, when they were borrowers of the loan, they would file claims against this coverage. But, and remember, men and women, so the spouses were also covered, but women as simply wives were almost never likely to file claims. So this really alludes to the kind of empowerment issue you're talking about, that perhaps access to healthcare has to be addressed also statistically in terms of, just gathering all the data and getting more information at the disaggregate level. Now I'd like to move to you, Dr. Anand. Having seen some of the evidence that we presented based on the NSS, what is your take on the relevance of data, the inadequacy of data, but perhaps also the usage of the existing data sets that we have in terms of addressing healthcare concerns in India?
Thanks, Shamika. And let me thank both Brookings and Nehru for organizing this event. I'm very pleased with this effort. In large measure because while we have been producing data, it gives us a great deal of pleasure when actually the data gets used, because one of our complaints have long been that there has been inadequate use of the data which is generated. And I want to use that as a starting point for emphasizing both the exercise which you've done and what we need to do a bit more just in using data. Maybe that will help this discussion a bit better. First of all, in health, as in most areas of social studies, there are broadly two broad approaches to data collection. One is direct data collection, where we go to a household and ask information through either sample surveys or censuses. Censuses, by their very nature, are very limited because the scale of the population in India makes that every census is a huge exercise, and you can only canvass limited information because if you do it at such a scale, your scope will always be limited. So we come down to surveys, and other big data source which is available traditionally in the area of health all over the world and in India is administrative data which we gather from establishments. I think what we must understand is to get a correct picture of any sector, certainly health, you need to look at both these data sources together in a holistic manner, because each one of them brings their own perspective to the data. The NSS data is useful, but it reflects a particular worldview. Specifically, it is important to understand how is the NSS data collected. It is collected by a surveyor visiting a household and asking a set of questions based on a schedule which has been designed. The schedule, yes, has been designed by a set of experts who are familiar with issues of health and health expenditure. We pay a lot of attention to the details. But ultimately, whatever information is recorded on the basis of that conversation which took place between the investigator and the household respondent. It is limited to a large extent by their understanding and focus on the problems which they are describing. I'm making this point because I know also use the term health and morbidity in there as part of the survey description. This is not a very good way of measuring actual morbidity related issues, because that is better done through administrative data, which is collected through hospital facilities where trained professionals are recording diagnoses of what the problems are. And so I should point that as a caution, because even though we have indicated sources of ailments in a number of places to try to get a sense of expenditure, these are perceptions of the respondent and are therefore as reliable as the respondent's own understanding of the problem, and that is one aspect of this data which people should keep in mind in their interpretation. Let me first take you through understanding survey data and its implications before talking about why we need to strengthen administrative data, because I do want to make a pitch for that. Shamika pointed out something very interesting. She said there is a statistic gathered from establishment data, which is basically talking to government and insurance companies, and you come with a figure of 25% coverage of insurance. Here, from the health expenditure side, we report 15%. Now, why does this happen? First of all, I think somewhere in the definition it's there. We have actually this time looked at out-of-pocket expenses rather than getting into possible things which are receivable by you or payable by you. Because we felt that would be very, very difficult to quantify and may be also very difficult to actually make sure it is reliable. Now, think about insurance for a minute, and if the insurance is paid directly to, in other words, if it is not a reimbursement system, but in fact it is paid directly to the facility, then there is no problem. The out-of-pocket expenses correctly record the component which is supported by insurance. But if insurance is reimbursable and the reimbursement is not swift, then it is likely that the household at the time of reporting to you when it is being asked about household expense may not A, be aware of the possibility of getting reimbursement, B, the individual responding may not even know that the reimbursement is possible or had occurred. All of these can definitely lead to the direction of reduction which we are noting in the figures. The second is a statistical problem. Insurance coverage, and particularly private insurance coverage, makes its profits by covering those who are not likely to need healthcare. Whereas when we are trying to measure health expenditure, naturally would like to sample those households where there is actual incidence of disease or inpatient coverage. So the directional bias in coverage, we will oversample households which have had incidence of disease, whereas the insurance company will overstress its effort in going out to households which are less likely to have, if you like, disease. Technically, as statisticians, we should certainly correct for this, and our estimate should be the same, but in practice it's not going to happen because there will be some bias created by these coverage biases. So I'm pointing out that there is a certain natural element to the divergence between establishment data and survey data, which will occur when you interpret it appropriately. It's possible that that may happen. That was one of my points. I said that you must be careful to interpret survey data. Second part of the interpretation, and that is, Shamika alluded to this, and I think I need to emphasize this, a rise in expenditure doesn't necessarily mean things have become worse. For a poor person, health is an important domain of expenditure, but it is one amongst many. The ability to spend increases as his level of expenditure rises. Shamika pointed out that the overall expenditure in the country between 2004 and 2014 has risen. Amongst the poorest households also the proportion has risen. When you are really destitute and you are probably just barely able to meet your needs, you do not have the ability to spend on healthcare sometimes. And you may, in fact, suffer the disease without being able to pay for its treatment. As your earnings rise, you are still poor, but your ability to spend means that you are actually spending more. So it's not surprising that you may see a disproportionate rise in the poor, especially if there are not enough insurance facilities available for them to actually see a very sharp rise in healthcare expenditure at the lowest level. So this again is a characteristic of a household survey which is asking people what they actually spend. In any case, the interpretations of data and understanding how the survey technique helps is an important part of it, which is why we do spend some time in describing in all our survey results the basic methodology, the methods concept, and in fact, our detailed methodology data, questions asked, concepts are also available on the website for those who are interested. I now want to turn to a slightly different take and why it's important. I started off by mentioning that survey data only captures household perceptions. In order to get a complete picture of the health position in India, it's necessary to have more complete administrative data. Now here there is a catch-22. By and large, and I don't necessarily mean to criticize Shamika or the Brookings for this, since that data is patchy and unreliable, NSS data covers everybody, there's a tendency to say that light is there, let's focus here. I would urge you not to do this. Please correct for the coverage issues and work with the administrative data as well. Because A, it is necessary to convince government that they need to pay attention to administrative data. Government is currently doing a lot to improve the quality of administrative data. Public hospitals, Health Ministry has created a huge program to capture facility level data from all the public health facilities, so down to the PHC data will be captured. We should try to look at that data, analyze it, because that will be better data for purposes of morbidity, patient care, who is getting to use the public facility, something which Dr. Kumaramangalam has just mentioned about the discrimination between men and women comes out better when you look at facility data rather than household data, because household will give. It's very difficult for any outsider to get a sense of how the expenditure works out between different categories. It's the perception of the reporter which influences. But if you have the facility data, you can actually see who showed up for treatment. As she says quite rightly, you will find women do show up for maternity-related facilities. But when it comes to treatment in other ailments, in cardiology-related things, in diabetes, is it that most of the patients in OPD or in patient care are men or women? How frequently are women likely to be taken up for elective surgery? If we can get good administrative data, we will get a better sense of the extent to which there is a bias in healthcare provision. Secondly, we would get a better sense of the expenses as perceived from the establishment side. At the moment, we only have public health care. Now, here there is another pitch. Once you start using it, and I think there's an important point to convince government, that there is an equal need to mandate a certain minimal amount of recording and data collection in the private sector as well. This is a piece of advice I have given Health Ministry in the past. Analogous to what they are doing collecting data from the public health facilities, some effort must be made to capture basic data from private health facilities as well. Given that they account for close to 70% of patient care in one form or the other, not having any coverage of private health facilities creates a problem. At the moment, the reporting is limited to certain contagious diseases and certain types of ailments, and some programs of ICMR trying to build up registries for certain chronic ailments. But I think there is a need for a more systematic effort on data collection of private health agencies. We are planning to do more survey-based efforts covering both health expenditure on a regular basis. The next survey will be done next year, not a gap of 10 years anymore. We are also planning to start, we are doing on a pilot basis this year through NSS, an establishment survey of service providers, which will also include inter alia health. But the sort of survey we do and agencies like ours will do will principally focus on only operational and accounting side of their establishment. The full operational side of their establishment in terms of patient care, which areas of medicine are the care taking place, and the things which health professionals will do, can only come if proper administrative records are mandated and are kept in these facilities. So I'll stop here and hopefully we'll have discussion on this. Thank you.
And hopefully there'll be more questions on that. One specific response to you, TC, is that at Brookings we have just entered a collaboration with the NDH, the National Accreditation Board for Hospitals, where they have agreed to share the data for 1,000 hospitals, of course all adequately masked. But the idea is to do exactly that, to get out to the hospital level to see more administrative information. And also we are helping with the NITI effort of tracking the performance of the district hospitals in the country. So we are absolutely, that was almost like a segue for me to promote some of Brookings' ongoing work. I'll move to you, Dr. Ketrapal. I think the UN did very well in terms of compelling India to sign on the kind of international certain objectives and goals related to maternal mortality and infant mortality. And I think we've done, the evidence shows that we've done well on those two fronts. But where do we go from now? And what does the UN or the WHO in particular, what is your recommendation for India's future public policy as far as healthcare is concerned?
Yes, first of all, Shamika, I'd like to correct you on that. I mean, no country is really compelled to sign it. They all sign voluntarily because they want to sign it and they want to be part of that whole movement where they are trying to reduce either infant mortality or child mortality. Let me take you back to the MDGs, which were signed in the year 2000, and where we had 3 very clear targets related to the health sector. The first was the reduction of infant mortality, which was MDG 4, reduction of women's mortality, which is MDG 5, and then we came to the 3 diseases of HIV, TB, and malaria, which was MDG 6. All countries around the world, over 100, and there are heads of states really who had got together in New York General Assembly to sign this. That came to an end last year, in 2015. Now, as far as India is concerned, India did make progress, but did not reach the goals that they had set for themselves to reach, in which this MDG agenda had set for them. Some countries around the world did, and I'm looking at my own region. There are countries like Thailand, Maldives, Bhutan, which could reach the MDG goals. Even countries like Bangladesh and Nepal did extremely well. They were also given the Secretary General's Award for the reduction of child mortality and women's mortality. India, as far as child mortality under 5 is concerned, should have reached the goal by now. 2015 is when we think, with all the data that we see, that India has been able to reach that, but they have not been able to yet announce it because it's not validated yet. That's not so worrisome. I think as far as the MDGs are concerned, that goal has been achieved, though not announced. Now when we look at the women's mortality goal, that is which bothers one more. And a lot has been said about women before me. And I do believe that that is going to be a trickier goal for India to reach, and what we in WHO anticipate that will happen in 2018. In a lot of discussions with India, we've been talking about this. Now coming to this, let me then move on. From MDGs, we finished last year in 2015, but the SDGs came in, which are the Sustainable Development Goals, which again countries around the world adopted in the UN General Assembly in September last year. SDGs are looking at a much more integrated agenda. It's a very ambitious agenda. It's not a vertical agenda like the MDGs was, that you have targets, you work towards them, you achieve them, and then you make a proclamation, you achieve them. It's not like that. It's a more integrated agenda, but a part of the SDGs are also looking at the unfinished agenda of MDGs. So women and child mortality will again get addressed there, and we in WHO are following it up with India on a very continuous basis, because we do want that India should not be left behind. And in my region, if I look at the population of my region, it's 1.8 billion population, out of which 1.3 billion is India straight away. So if India does not achieve any target or goal, the region lags behind, and that is something that bothers us in the Southeast Asia region. Now coming to the points that was made earlier by Lalitha about women being really not given the kind of importance they could in a family, I totally agree. It's more like a male child syndrome, which has been carried on for generations in our society, and therefore there is a kind of a back step that women take, and I feel very often it happens voluntarily. They're just so used to doing it, and very often our surveys show and various studies show that the health-seeking behavior of women is low. They always give themselves the lowest priority. So if a child is ill, they'll rush the child to the hospital, the husband is the breadwinner, he will get the importance. But the woman herself does not seek health care the way she should. That was a point made by Mr. Anand also, that when we had surveys looking at the importance and the priority of health to a common man, our surveys show that health comes sixth in priority. They're more worried about food, they're worried about shelter, they're worried about clothes, they're worried about jobs. Health is really not that high in the scheme of things. And that is perhaps why the point that was made earlier by someone, that, yes, by Lalitha, I think, that education is given importance. In various states of India, I find industry is very important because they feel that is where the money is coming in and that is where the jobs are. But health does not get the kind of importance it should, even when we compare it with education, and we look at the social sectors together. Education definitely gets much more importance than health. And I do feel that it is for people like us to really bring up health in the priorities, and I do wish CK was here today, because now India is revising its or forming its new health policy, and it would be extremely important for India to address these gaps, which are so prominent and which are not getting addressed the way they should. I would also like to make a comment that was made on the local foods, because I do find that that is something very significant. And that is something which is ignored very often. Even if you look at mothers feeding their children, they are looking for infant food which is packaged and readily available in a tin, rather than looking for local food which may be much cheaper and as effective. I remember I did a study with the World Bank way back in the 1990s, the Tamil Nadu Integrated Nutrition Project, in which we tried to show that it was really local food which would be sustainable. The costing is not, it's so cheap, it's readily available, but what we need to do is advocacy and train mothers to see that this is extremely important. One comment on what Mr. Anand said, we all agree that yes, data in our country is not collected the way it should, and I do feel that even if you go to the facility level, you may not get the kind of data you think would be available, because the data, we have tried to get it for our studies. Data is not available very often, and if it's available, there is a lot of hesitation to share that data. And that, I think, would become a major challenge and may not serve the purpose. That is why we find that various studies show various results, even though they are dealing with the same subject. And sometimes you're very startled to see that the results coming out are conflicting results, so the percentages coming out, even in a study like what you've done, Shakti. The results may be different from other results, and that happens because the data is such. So we definitely there is a need in our country to strengthen data.
Thank you, Dr. Krishna. Now, in economics, and now there is a move towards behavioral economics, because we know that nations like us, humans, aren't always rational. So we like commitment devices to try ourselves into doing what the right things are. And I pursue the MDGs and the LDGs as such. These are really commitment devices that countries sort of tie themselves to in order to attain these long-term goals. Now, I'll move to our final panelist, Dr. Ravi. As someone who has been working in public health in India for a very long time, so you have seen some of the evidence. What are your thoughts on what should be our priority in the next 10 years in terms of healthcare efforts?
Page of commitment devices, the Sustainable Development Goals, which we subscribed to in September 2015. One of the targets, and which is actually very pivotal for the entire health goal, is delivery on universal health coverage. Universal health coverage has been defined by WHO as every person having his or her health needs met without experiencing financial hardship. The WHO has very helpfully framed a cube to try and configure this concept, in which you have three dimensions. One is population coverage, second is service coverage, and the third is cost coverage. Now, there is likely to be a differential emphasis on which of these is being prioritized based on the perspectives of the different stakeholders. Political decision makers are more likely to be interested in the population coverage. The more people you cover, better for equity from an enlightened viewpoint, but also better for voter satisfaction and political popularity. Health professionals are much more interested in service coverage because they feel they must provide the best of care to each patient, and therefore the more the number of treatments that are available under the framework of universal health coverage, the more number of diagnostic tests that are available, and the more number of conditions covered, the better it is. When it comes to cost coverage, it becomes the burden of economists and health system managers, the civil servants. And they would like very much to reduce out-of-pocket expenditure, catastrophic health expenditure, and healthcare-related impoverishment, while being fiscally prudent and not busting the budget. So that is where the tension, the dynamic tension between these three perspectives will shape the pace and process of universal health coverage in any country, but particularly in a country with a mixed health system like India. So let's look at how India has performed in each of these three areas based on the data that Shamika has provided. When it comes to population coverage, certainly we have increased the population coverage by way of a large number of government-financed insurance schemes. Private insurance is still a minor player. We have the RSBY, the Rashtriya Swasthya Bima Yojana, which is likely to now metamorphose into the National Health Protection Scheme from April next year. We also have a slew of state-funded insurance schemes, started with the Rajiv Arogya, but then had several similar schemes coming up in other parts of the country. Even the nomenclature might change, but the schemes have essentially remained state-sponsored funding for tertiary care, whether RSBY is mostly secondary care. But all of these have actually increased an opportunity for people who hitherto could not access inpatient care for serious ailments. And we have seen that inpatient care has actually gone up now. But is it providing the right quality of health outcomes? That is uncertain. But when we come to the third dimension, that is cost coverage, where financial protection is considered to be one of the key tests of universal health coverage, though not the only test, there seems to be an abysmal failure on all the three indicators, whether we are looking at out-of-pocket expenditure or catastrophic headcount of households, or in terms of healthcare-related impoverishment, which still stands at 7% in terms of overall percentage, but given the population rise, the absolute number of people in poverty is increasing as a result of healthcare expenditure. So these are truly disconcerting data, which suggests that however nobly intended, our government-funded insurance schemes are not delivering on the key objectives. And even in terms of quality, which is something that we have not been able to measure through these kind of surveys, but other surveys have actually shown, limited, that we do have a problem. Even if access is increased, it does not necessarily spell out coverage. We have seen that Janani Suraksha Yojana actually increases the number of institutional deliveries, but that did not seem to have a relationship with outcomes on maternal or neonatal mortality. So quality becomes another major area of concern when we talk about health systems. So we cannot talk about universal health coverage without talking about the ability of our health systems to deliver on all of these three dimensions. Now, clearly, one of the areas that we need to pay attention to is the huge rise in inpatient care, and particularly in urban areas. Now, one might say this is a great opportunity for people who previously could not get their treatments in private hospitals or in government hospitals, not access care through the mechanism of insurance schemes. But it also represents a failure of our primary healthcare system. Fundamentally, conditions that could and should have been prevented much earlier on through care of risk factors and a variety of minor ailments have been allowed to proceed to a level of seriousness and complications that hospitalization becomes necessary. But there is also an additional element. The additional element is that when people can only take recourse to hospitals because primary care is not available easily, especially urban primary health care is still to be implemented. And once they go to a hospital, now that the insurance mechanism is there to subsidize their admission and care, there is an element of induced demand that comes in. So the person, even if not requiring hospitalization, may get hospitalized because the patient is now being seen by the healthcare provider as an ATM to collect cash. Did I say ATM? Wrong analogy this month. However, we must recognize that these are the kind of conditions that we must really address if we are serious about universal health coverage. We need an integrated care framework where we do have a much greater emphasis on primary care and link it up effectively with secondary and tertiary care through a network of providers with an appropriate gatekeeper function for primary care and return from secondary and tertiary care to primary care. We also need standard management guidelines. We can't afford to have a laissez-faire system in which, as has been pointed out, expenditure on diagnostic tests and treatments has gone up hugely in urban areas. Why so? Because no standard management guidelines are being followed, and doctors can prescribe any amount of diagnostic tests, and there is an asymmetry of information that prevents the patient from even lodging a simple question, do a child protest. So we need standard management guidelines, and now if the government is going to be spending money on purchasing health care, both from public and private providers, and in a mixed health system you cannot exclude the private providers, then it needs a strategic purchasing mechanism in which they can actually get quality services with clearly defined deliverables and clearly delineated accountability mechanisms. Without that, it becomes an entirely laissez-faire situation in which the natural tendency of hospitals is to make more and more money, even if it is not appropriate care. So this is where I believe we must refashion our entire healthcare system. We are now moving on two rails. One is the National Health Mission, which
was previously focusing almost exclusively on maternal and child health, now is aiming to become an integrated platform for other national programs, including non-communicable diseases. Now, the government wants to screen people for hypertension and diabetes, but that's only one measure. What happens after the screening? Are the services available at primary and secondary care levels to cater to the increased demand? And we know in a mass screening, there are likely to be a large number of false positives. So all we are likely to do is to spill them over further into hospitals for unlisted design for universal health coverage. And something that actually involves both the center and the states. We need a large enough risk pool to be created. Tax-funded healthcare is the largest risk pool, but even if we cannot do entirely by tax funding, we need to integrate all our insurance schemes and create a large enough risk pool across the country, and then provide essential healthcare through a well-defined essential healthcare package, which can be expanded over time as resources increase. Lastly, let me say that yes, our public financing is very low, 1 to 1.2%, and we must indeed increase it, because without improving our health system's capacity in terms of health workforce, infrastructure, supply of essential drugs, we will not be able to deliver. But even we are likely to be constrained in this, because our tax to GDP ratio is 17%. We are unlikely to increase our taxation levels because we are looking at an investor-friendly environment. Apart from innovative health financing like raising tobacco taxes, etc., one thing that we must recognize is that even countries which have actually been spending a lower amount of percentage GDP at 1 to 2% on health, like Costa Rica, Cuba, Chile, have achieved excellent health indicators because they emphasize primary health care. And if we do not do that, we will see our hospitalization rates spiraling up and our hospitalization costs spiraling up, damaging both health and the economy.
Thank you, Dr. Reddy. That was truly insightful. And perhaps it is time to make this renewed push to integrate, to push for primary health and the gatekeeping, which is saying is very essential. Because in the long run, pushing greater hospitalization just leads you towards an economy like the US, where they spend 18% of the GDP and have the same health outcomes as a Singapore, which only spends 4%. So obviously, the design of the health system becomes very critical. Thank you very much. That was very insightful. Now we have time for a few questions from the audience. So if you could keep it very short, just introduce yourself and ask a question. And also the panelist whom you're referring to.
Good afternoon, everybody. Thank you for inviting me here. My name is Meenakshi Datta Ghosh. I have enjoyed the panel discussion. I have a few comments. When I read the topic, Health and Morbidity in India, Evidence and Policy Implications, I did not realize that it would, the deliberation, except for the last one, would be mostly limited to, women and child care. It was good of Dr. Reddy to bring into the room the growing incidence of non-communicable diseases, and there's a lot else and there's a whole other world out there, in health and morbidity besides women and child care. The second thing is evidence and policy implications. I think the evidence is so well known. Dr. Anand has been talking about this in various fora, and we all know after the 73rd and 74th Amendments how healthcare on paper is meant to have been decentralized to Gram Panchayat levels, but we all know that that is not the case. The content, the pace, and the progress of decentralization and devolution of anything, including healthcare, has been left entirely to state governments. And state governments do pretty much as they please. And the central government is unable to enforce this kind of devolution. And that is one reason why we simply do not have organized primary health care in this country. My second observation is that deficiencies in primary health care have been located across the world, including in the National Health Services System of the UK. And on last reading of the numerous attempts at modernizing the NHS in the UK and in fixing some of its very serious problems, is they are looking at bringing in accountable care organizations, the kind that Dr. Reddy spoke about just now, and which are fairly prevalent in the US. But I don't know whether, to what extent the UK will follow the US system, but at least we can bring in elements. I think my third observation is that it was in the late 90s, the early 2000s, when the UK brought in a divide between payer and provider. In this country, we don't have that divide. Government is both the payer and the provider. And although private health servicing has spread far and wide, but you know, the divide remains. So if government is going to purchase health services, strategic purchasing is actually what is needed now. And this evidence and policy implications should now be focusing on actually how we're going to restructure the delivery and servicing of healthcare. That is what the policy implications of the evidence which has been accumulated is.
Great, thank you. Could we take a couple of questions and also keep it short, and then please say whom are you asking the question to, Mr.
Hello, I'm Ananya Avasti from Deloitte Consulting. My question is, it's open to all the panelists. While doing a maternal health report, I have a very short question that with the amount of investments that have gone into NHM and RMNCH services, do you think and we haven't seen concomitant decrease in the indicators on maternal mortality or even morbidity. So do you think it's an issue of quality of care that is being provided at the healthcare facilities, that we're able to bring the mothers to the healthcare facilities but are not providing them good quality care? Or do you think that the question is much larger or hinging on the lines of social determinants of health, where probably investing more money into NHM and NRHM might have very little marginal returns for productivity, and maybe a multi-sectoral action is something which will actually bring us to the MDG target for now?
Great, thank you. If you could just give him the mic. I'm sorry, he already has a mic too.
My name is Ramasundaram. I'm Shakti's batchmate in the civil services, but now in the private sector. Lalitha is an old friend. My point is, if the conclusion is that we are not spending enough on health sector, we need to just go back to the 1993 World Bank report, investing in health. I think the problem with the health services is government thinks it's a favor done to the people. You don't get anything in return. If you invest in infrastructure, GDP goes by 0.5%, 0.2%. This obsession with whether it's 7.6 or 7.5, that's the age we live in. So unless the correlation between investing in health and GDP growth is established, as they did in that report, you won't get sufficient funding for health. Just take an example. Air India, which is used by less than 0.1% of the people, there is a bailout package from the previous government for 30,000 crore, of which 24,000 crore has been sanctioned already. It's, as a per capita expenditure of budget money, where India can survive in the market is fine. But it is using budget money to bail out something which is used by a minuscule population. So you have to bring in that, maybe the name Maharaja has to be changed to Maharani, then they won't get enough money. So the linkage between health allocation and GDP growth is what will make the policy makers put in more money into the health sector.
Thank you.
I have the mic.
Could you please have the mic? Thank you.
Yeah, I have this question addressed actually to Mr. Anand and of course Dr. Ketapal and Dr. Ravi, and one specific question for WHO. My name is Vivek Sehgal and I represent PhD Chamber here, the Health Committee of PhD Chamber. One is, I think one very good point which Dr. Reddy brought about was the integrated universal healthcare system. I really want to talk about, or somebody to comment on, an integrated health policy, which is what we've been also talking about at the Health Ministry. Considering they are not here today, but I'm sure the message can get across. Today we have created a lot of hype around the Ayush system as well. And when it comes to primary health care, which is in any case a challenge, I think there needs to be an integrated health policy for providing, let's say, primary and tertiary health care across all these systems. And they all need to be actually sewed into a single thread. That is one thing which is very important, because another thing which Dr. Reddy talked about, everything is happening in piecemeal. So I think this is applicable to the overall healthcare delivery in the country today. So we need to actually put that all into a single string, one. Two, I think there was a very good thought process which I had come about in one of the earlier WHO India conferences, where was healthcare in all. Healthcare in all sectors is, I think, again very critical and important, and I think the policymakers, including WHO, India through its, or WHO regional office through India, can actually take up, and whether they are doing it as of now, for healthcare in all sectors, which means like we have funds for, let us say, the Northeast region in the Textile Ministry for that matter. So why not health? So these are my two points and questions directed to the, and are these things being also pursued as health policy issues with the Health Ministry?
My question is to you, Mr. Anand. You talked about facility level data, and I have been studying the HMIS data for some time, and I happened to look at some of the district level reports that are uploaded. And we found that some of the data that is uploaded on the websites have so many discrepancies, and these reports which are uploaded are not being able to follow the validation rules that are set for themselves. So there is obviously, the effort is laudable, but one, what you said that, a lot of data which is beyond maternal and child mortality and these health indicators would be available, one is not true. I mean, there is very little data beyond that scope that is available in these reports. Two, this data over the years is actually deteriorating, is what we found in our analysis. The first, so my analysis shows that over the years, the quality of the data is just deteriorating. And in some states, that deterioration in data is actually worse. Some states have actually improved. So my question is that, is it not possible that an ecosystem can be created where not only facility level data is encouraged, but there has to be an ecosystem where data quality audits is also enforced or self-enforced, and that system also has to be put in place so that not only facility level data is encouraged, but that auditory mechanism is also enforced on the states.
Great, thank you. Could you identify yourself?
Oh, sorry, my name is Shruti and I work for National Institute of Public Finance and Policy.
Thank you. Now, in the paucity of time, and also, we can have further discussions and questions over tea. Shakti, I've just invited the audience to tea on your behalf. Okay, so now I will recommend each of the panelists, starting with you, Dr. to respond to some of these key questions.
Reddy, I still need to talk to you.
Well, corporate over coffee.
All of you all I need to talk to.
Well, I would not have coffee with Karan, but I'll have it with you. All right. Very briefly, on the maternal health issue, actually you're absolutely right. It is a combination of factors. If there is a underfed girl child and an anemic adolescent being propelled into early marriage and improvident early maternity, then institutional delivery is not going to make a difference. But the quality of institutional delivery also is important, so you need to address all of these issues. Second question was regarding the case that investing in health actually yields an economic return in terms of GDP growth. After the 1993 report, last year, or 20 years after that actually, the second commission was set up, the Lancet Commission on Investing in Health, chaired by Larry Summers and Dean Jamieson. I was a member of the commission. The report was published 1.5 years ago in Lancet, and a fresh version is also going to come up. So the case is becoming stronger. In between, the WHO itself had a commission on macroeconomics and health. So the case for investing in health, even not only to protect economic development and prevent poverty aggravation, health poverty reduction, but even as a lever for economic growth is being made. There is another report I'd like to refer to you, which is a UN high-level commission chaired by President François Hollande of France and by President Zuma of South Africa, which was released in September this year, which is looking at health workforce expansion and economic growth globally. Previously, an economist called Baumol made the point that health is only a cost, but they've clearly identified how investing in health workforce expansion not only helps the healthcare sector, but where employment is actually diminishing in industry, agriculture, or even in service sector, this is an important lever for economic growth, health workforce expansion. And India, with its huge demographic advantage of having young people, especially women, yearning to enter the labor market, must look at this as an opportunity. Then in terms of integrated health policy, certainly I believe it's absolutely essential. It makes the case. The same issue about multi-sectoral engagement, social determinants of health, all of this will have to be integrated. We have to look at health beyond health care, and that is where this integrated framework comes in.
Coming to the first question on quality of care, now that extends across all programs of the health. As far as health is concerned, even the disease control programs, leave alone just the maternal health programs. Quality becomes important, and that is also reflected in the study, though they do not touch on quality, but you see that a large number of people in India still go to the private sector. Now, why do they leave the public sector and go to the private sector? That really is connected with the perception that the private sector gives better care. Now, whether it does give better care is a different question. And there are studies which show that the private sector does not necessarily give better care. But there is a perception among people. There is, of course, there are things like the time taken to really take the patient in, less noise, better cleanliness. These are the kind of things which people perceive and believe that the quality of care is good. Coming to investing in health. Now, health has to be seen as an investment by the government, which is very often not done. And we do find even in India that the allocated budgets for health are not optimally used. Very often you find that we keep talking about investing more in health, and India does invest perhaps among many countries around the world a very small amount in health when it should be investing much more. However, even that is not optimally used. And I come to the question of planning. Perhaps when we plan our healthcare delivery, we don't give enough attention to it. I have worked at the state level, and I have seen that where you have a healthcare facility is decided by the health department, but whether that healthcare facility is going to have water or whether it's going to have a road going up to it is not decided by the health department. That is another department which decides, and very often they do not meet and decide that they are going to make one facility to focus. So it's not uncommon to find a health facility where you won't have water supply, or you have a health facility where there's no road going to it. So that is extremely critical, which I find missing here, which needs to be addressed. Then we come to the referral system. There is no referral system really in India. Anybody goes anywhere, you go to AIMS and you find a whole lot of people there, and very often people come there with very common ailments. And that brings me to the point of a strong primary health system, which was emphasized before, which was perhaps with good intentions started, but it never really got working. And why does that happen? There are a whole lot of operational issues there, because doctors are supposed to be there, but the medical professionals don't want to be there, and they want to be closer to the urban areas. Now, I don't say that we should blame them, because they don't find the facilities perhaps which they are looking for in a, say in a secondary level hospital, which they are looking for in a primary level hospital. They don't find it. They spend all their time trying to get out of that particular facility. And I say this with experience because I have handled the health system and have been health secretary, and I used to wonder always that why is it that doctors spend so much time wanting to come out of the rural areas and go to a secondary or a tertiary level hospital. But some kind of a system has to be evolved where perhaps we need to think of nurse practitioners. Let nurse practitioners be there. Also in our system, we try to discourage people from the same area getting a job in that particular health facility, which to my mind is not the right way to proceed. If we want an A&M to be in a health center, she has to be from that area. A young girl, 18 years old, is not going to feel safe being in a sub-center which is far away from where the real population is. And why did these sub-centers come up in these areas? Chiefly because it's on donated land that they came up. So therefore, government was willing to put in and build centers. They were building infrastructure, but the land was donated by the village panchayat. The panchayat wouldn't donate land right in the center of the village. They would donate land at the periphery of the village. So there are lots of operational issues there. There are lots of planning issues there which need to be addressed. This brings me to the point of health for all and an integrated health policy. We all know that health is multi-sectoral. We've been hearing it for years and years, right from health for all. We've been hearing about this. However, practically we don't see it happening because there are many departments involved. You need nutrition, you need water, you need sanitation, you need all of them to work together to be able to have integrated healthcare. And that becomes a huge challenge, and very often because of health issues, not because of other issues, which perhaps there are ways, of course, of overriding those, and many states in India itself have found those ways. But these need to be standardized, propagated, disseminated, because I find very often the left hand doesn't know what the right hand is doing. Even if there are good practices, they are not shared. And therefore, I do believe that health in all policies and all this remains a slogan. WHO has been propagating it right from the beginning. We just had a big health promotion meeting in Shanghai, where again this was the subject of discussion. However, practically, we don't find that happening. And for reasons which I have mentioned, which are mainly operational issues.
Thank you.
Ma'am, I have one thing. WHO, we all work.
Could we take this, because I think, in the interest of keeping everybody's time,
No, I just quickly think, talk about vaccine hesitancy. Why? If you've seen that it's already been published by WHO.
no, we really must take this offline, I'm sorry. Can we have Kishri and Lalitha give responses? We can take that.
Both Dr. Reddy and Mr. Chapter have addressed a number of issues. Let me take with a few points. One, I'll take the point which you raised about the data from HRMS and the need for validation around it. I think that's an important point, and I should emphasize that we tend to have compartmentalized ways of thinking. Data is not the job of statisticians. And there is a tendency as far as data is concerned, that's the job of statisticians. We will worry about policy and fact is, data comes out of policy and implementation and governance. The process of governance must be data integrated. I'll give you an example. I have seen, this is part of my personal avatar of being a statistics person, so people come and consult me with issues about data. For one of our large private hospitals, the records of patient care, because all discharge summaries are in some of the better than private hospitals computerized, so somebody was doing some analysis for a thesis and that to me. The point is, the hospital management should be looking at that data as part of its administration and governance practice, and it was very clear it was not being done, because you could very clearly see mismatches in the data in the discharge summary in terms of test results and the final doctor's advice, because the doctor's advice should have seen the results and said you need to come back and do things. It's not there. It's very easy to point out that we function in our governance and regulatory platform in a manner which is independent of data. If you want the quality of data from administrative sources to improve, the only way that can happen is if the governance structure, and I don't necessarily mean only state regulation, it's also private regulation, has to incorporate the data into their work. What you can bring out are the inconsistencies, and I think you should bring them out. The fact is that inconsistencies are often the basis by which you can point out that something is happening and we need to be focused on what is going on. As a statistician, I'm plugging for greater use of administrative data. I'm plugging for the fact that we need to bring this data out. We must have facility level data. I'm very supportive of the health ministry move to create a facility level profiler where all facilities are required, at least in the public healthcare system, to load data. I would actually like to go further and ask them to mandate a minimal amount of data reporting for all facilities, regardless of whether they're in the public or private domain, and that data should be brought out. But it's not enough that the data comes. The quality improvement which you're asking will happen if the data starts getting used by the regulators. I'll give you an example from the economics side. We get very good data from the financial sector. SEBI and RBI gives us high quality data. You can work with the data. Many of my colleagues, Shamika's colleagues, have worked with the data. Brookings works with the data and do a lot of analysis. The reason is that they are principally collected for the regulatory purpose. The regulator collects the data, uses it for their purpose, makes it available to all of us, and we work with it. In the health segment, the regulators, for the most part, work without data. Our job is to persuade them that they need to start working a lot more in data and asking for a lot more data from the facilities which are under their charge. So it's not that we should therefore try to ignore this and look, the tendency is for the academic is to say, all right, in that case, let me just do a survey of my own, do a small study of my own data. I say not to fund me, I'll do a little study. I think that would solve the problem. Since the purpose of this discussion was how do we build data into better healthcare, the only way is if we keep pressing for them to build that into their analysis. That's a larger philosophical position insofar as data is concerned. I think many of the points have been made about linkage institutional healthcare, so I don't really want to add to this. I think there is a point, and I'll close with this, something which we started with, and we tend to have a notion that the center must do something. And when you talk about a federal structure, it is important to understand that the provision of primary care is in the constitutional domain of the states. We have a very peculiar system which creates a bias towards tertiary care. And why is that? Because till now the center was better funded, but the center's principal responsibility was not primary care. The center could establish an aims. So we are now establishing aims in a large number of places. What we need is a system where the burden of expectation in the center needs to be reduced and the burden of expectation in the states need to go up. The question should be asked at every state forum as to what is your state doing for healthcare. And in fact create state report cards comparing one state to the other. It's not the case that all states are equally bad. There are many states which have done remarkable things in healthcare provision, including facility level data from states. I have seen the databases from some states. They have got virtually universal coverage. All their facilities on the database. They get regular reports coming in. I think we need to bring that out, create an environment in which the state governments who have the principal constitutional responsibility to govern and discriminate, because without that you will create this peculiar thing of a well-funded, centrally funded tertiary care establishment being the norm of treatment which everybody aspires to. So everybody then seeks to replicate that. And that doesn't create the sort of integrated healthcare system which Dr. Reddy is talking about. If we want to build from the primary healthcare, the principal focus of attention will have to switch to the states.
I'll just restrict my replies or comments to two things. One is that nobody here actually talked about preventive healthcare. I was meaning to, but I forgot. I'm sorry. The fact is that the second thing is that I agree with what Mr. Ramsundram said. That is the economic argument for healthcare. I don't think much research, if any, has been done on the cost of what the exchequer has to bear in terms of loss of productivity, loss of man days of work, etc. If anybody falls sick in the family, especially when it comes to women. Also, you find that a lot of what we call lifestyle diseases today can be prevented when you educate people on, for want of a better word, what we could say preventive healthcare, which include things like good nutrition, decreased incidence on prepackaged foods, etc., that increasingly people are depending on, especially in the urban areas. But also, that investing in health should not only mean investing in infrastructure and in services, but also investing in education about what health and nutrition means. I'm going on overemphasizing perhaps nutrition, but also things like exercise, which is part of health in the longer run. And awareness of these things is very poor in this country, regardless of whether you live in urban cities or you live in rural areas. And much of the costs that governments seem to be bearing on palliative care, on curative care, could perhaps be, subsidized, for want of a better word, if we invest even half that amount on preventive healthcare. And preventive healthcare doesn't seem to be very high even in the entire scheme of health itself. We don't emphasize preventive healthcare enough. I think there's less research on it also. And I talk about it because when I deal with women who are in this country who generally suffer from ill health, again, regardless of what economic, what the economics of their life may be, poor, rich, uneducated, rural, urban, doesn't seem to really make much difference in this. I see that if only they have been taught about what health means in the long term, that's why I was talking about lifestyle and not just, looking at it only from the point of view of a pregnant woman or somebody who's going to have a baby or only anemia, etc. A more holistic view of it would probably cost less in the long run and would also improve GDP, productivity, however you want to couch the economic argument. And it is a fact that without the economic argument, we are not really going to get very far.
Thank you. Thank you, Harsha.
Extremely rich discussion with the potential to carry on, but all good things need to come to an end. And I want to give very strong thanks to the panel members, Dr. Srinath Reddy, Dr. Poonam Khetrapal, Dr. T.C. Anand, Srimati Lalitha Kumaramangalam. I want to thank the audience for your patience and your interest. I want to thank Dr. Shamika, Ravi and the co-authors, and Dr. Shakti Sinha, Director, Nehru Memorial Museum and Library, our partner in this event. And with that, on behalf of Shakti, I again invite you for tea. where you can continue the discussion. So thank you again. Thank you.